So first off, can you just explain your own background in oncology?
Okay, so my name is Greg Vidal. I am an associate professor of medical oncology at the University of Tennessee Health Sciences Center, and also a medical oncologist at the West Cancer Center and Research Institute. I do exclusively breast cancer, and about 40% of my time is dedicated towards research, from phase 1 to phase 3, and also some bench research.
Now, can you explain specifically how the COVID-19 pandemic has impacted caring for patients with HER2 positive breast cancer?
Thanks for the question. And again, I guess we could separate that in sort of early COVID and late COVID. Early COVID, the major concern there was immunosuppressants, having patients' white count being low, and how do we limit that in case patients get exposed to disease, and also how do we limit patients from getting exposed, that is coming into the center for infusion. So some of the early things that we did was to convert some of those patients who were coming in regularly, like for every weekly doses, into more longer intervals every 3 weeks. However, the every 3 weeks doses were more immunosuppressive. And so those patients would get GM-CSF support, which is a means of raising up their white count, at least shortening the interval that they were low. And so we would do these sort of things for patients. Other things that we've done early on was to, again, increase the interval at which those patients come into clinic by spreading out their HER2 infusions to 4 weeks instead of every 3 weeks. That is infusions for Perjeta Herceptin, for example. Interestingly, again, with HER2 therapies, those are very, very good therapies, but they're even better when they're given with chemotherapy. So they all sort of have a chemotherapy backbone, except for potentially the drug Kadcyla, where the chemotherapy is sort of attached to the Herceptin. And in cases where we could switch from chemotherapy plus Perjeta Herceptin to the Kadcyla, which is less immunosuppressive, we took that on. In more recent times, what we've recognized is that our patients, our oncology patients, were not necessarily getting higher infection rates when they come to our infusion centers. They may do worse once they get the infection, but it doesn't seem like they were had a higher rate of infection, partly because, one, we made a lot of changes to prevent them from being exposed, and those patients were a little bit more cautious about it. But what the data was showing is we're probably harming patients by not giving them the treatment rather than trying to limit their exposures. So now most of my patients come in to the center to get their treatments. Most of them get their standard of care treatments. And where we can, we try to make changes to sort of limit their immunosuppressant. But that is less of a concern now than it was before. Besides, in our centers, we take all the care that's recommended by CDC and probably even more, temperature check at the coming into the building, mask wearing for everybody, social distancing, and we still try to limit those patients from immunosuppressive medication, but overall, those patients have done well in my center.
So what sort of other changes have you all implemented as a result of COVID-19?
So a lot of it has to do, the biggest change is virtual visits. We do, and again, early on we did a lot more virtual visits than we do now, but almost all of my visits very early on in the pandemic was converted to, my visits were converted to virtual, where those patients were at their home and we could talk to them. But those patients still required, some of those patients still required coming in for the infusions. Some of those patients still required lab checks. We made it such that they could come in on a different day than the day of the infusion so as to not have long waits in the center. We provided some sort of outpatient lab, sort of out of the center lab phlebotomies, which was helpful for those patients. So virtual visit was the number one change. Again, we talked about the labs and other things, social distancing, limiting the amount of family members that come into the visit and are around the center was another big deal. That sort of limited, for some patients that was positive, for other patients who actually required the support, we had to make changes. So for a lot of those patients, we allowed their family members, even they're in the room, to be present virtually, and so they could participate and ask questions.
So looking at telemedicine specifically, how do you think telemedicine will continue to shape patient care moving forward?
Just purely in the amount of it that's going to happen. Previous to COVID, I did 0 televisits. I mean, I would call patients and talk to them about changes in their labs, new scans in the interval. But previously, either that was not billable, for example. And so now, because of changes of CMS, you can actually bill for some of those visits. But more than anything else, virtual visits, those patients, we ask those patients to come into the centers, even for times when they're not going to get blood, they're not going to get infusion, just for regular follow-ups. And so these are now potentially going to be done virtually. I don't think it's going anywhere. The biggest deal is the ability for centers to bill for those visits. And also not only bill for the visits, but make the compensation comparable to what you would have done if the patient came into the center. And so I don't think virtual visits are going anywhere anytime soon. We may not do them at the frequency that we are, but they're certainly going to be with us for a long time.
So with regard to surgeries having to be delayed, how do you think hospitals should handle the issue of all of these patients trying to reschedule at the same time?
So that was a big deal early on because elective surgeries, essentially hospitals just shut down. A lot of the breast cancer surgeries are outpatient surgeries, which could be delayed. And so we made changes by delaying some of the surgeries and treating those patients medically just to hold them off. And all at the same time, when that was done, what happened is once those centers opened up, those hospitals opened up, then there's a whole bunch of patients that now require treatment. And so getting them back scheduled appropriately was a big issue. Now, unless there is another big wave, again, which may be predicted for the winter time, most of the hospitals and the OR and the outpatient surgery centers are open. And I don't think, as far as I know from our hospital and outpatient surgeries, I don't think there's a big delay right now. But again, that may show up in the future.
So moving forward, do you think that clinical trials will move their focus to treatments which can be performed in a patient's home?
So that's a very, very interesting question, because part of what I do is clinical trial. And what we found is that during the pandemic, a lot of trials, again, trials are very controlled in that the centers that they are performed have to meet certain criteria. At the beginning of the study, certain centers are chosen, some are not. Not only that, is the amount, frequency, and type of visits. Those are very well controlled. So during the pandemic, when the early pandemic, when we were trying to dissociate patients from the centers stopping or removing those visits or doing them virtually ended up being something that was not part of the trial. And so we had to go back to the sponsors and say, are you going to give us permission to now do these virtually? And we did get it for a lot of those studies. For some studies, we just had to halt enrollment and say, once this is over, we'll get you back in, because for some studies, we just couldn't accommodate that. And so going forward, it would be very interesting, I think, for the new trials that are being written, companies, sponsors have to allow for virtual visits, for visits that don't require labs, and it's just a simple check-in. They may also have to reduce on the amount of just regular check-ins that occur, because COVID is going to be with us for a little while. My hope is once we get a better treatment, vaccines, that we can go back to life as usual. But for the next year and probably 2 years, I think new trials coming up have to place that within their design to limit the patients coming into visits, but also allowing for virtual visits when possible.
So that's all I had for you. Is there anything that I didn't ask that you think is worth mentioning in this space?
No, but I really thank you for asking about these questions, particularly as it relates to clinical trial, because it's not something that folks who don't actually participate and conduct clinical trials are thinking about. So I really appreciate the question, and thank you for having me.
Definitely. Well, thank you so much for meeting with me. I really do appreciate it.